Hello and welcome again, everybody. I trust you all here and at home have had some morning tea and a nice little break, and we are ready to get back into it. So my name is Kathryn Woolfield. I'm here on behalf of Doctors for the Environment Australia. Before I tell a bit more about us, I would like to acknowledge the traditional owners of the land on which we stand, and also the Gubbi Gubbi people, the traditional owners of the land where I live and work, which is a great privilege, and pay my respects to elders past, present and emerging. So Doctors for the Environment, we're very privileged to be asked to chair a session. For those of you who don't know, Doctors for the Environment, we're an organisation that's been basically a charity organisation that's been around for 20 years now. We're a group of medical students and doctors, and our goals are really very much aligned with the purpose of today's session. And in particular, we are focused on addressing the devastating impacts of climate change on human health and the solutions needed to address this grave threat. There are state committees, so I'm on the Queensland State Committee, and there's a couple of others in the audience as well. And we have special interest groups. So there is a healthcare special interest group. So anyone who is interested, I have even managed to put a QR code up here. So I would encourage you, if it's something that aligns with you or you know somebody who would be interested, to look at joining. You can contribute in a number of ways. So you can be just a financial member, but we also do public campaigns, direct advocacy. So that's meeting with health ministers, meeting with government officials, for example. And we've done a lot of direct liaison with medical colleges, and we work very closely with a lot of aligned organisations. So Climate and Health Alliance, for example, AMA, and my college, which is the Australasian College of Emergency Medicine. We do letter writing, some articles, and there's also a bit of fun. So some socialising, fun runs, and also there's a Moreton Island trip, which is what the medical students will often do, which is also part of a rehabilitation. So this is the topic for the next session, really probably quite the simple problem, the big three: energy, buildings, and scope 3. And if we can solve this, then really we are on the way to achieving our goals. As we've heard from the first panel, this is really the greatest challenge that we have. We need to do more from a healthcare sector, as we are contributing so much as well of the emissions, carbon emissions. We need to do more to reduce that. So we're going to have presentations, and then we have a panel afterwards. So as you have done before, if you can put your questions on the Slido, and after everyone has done their talks, we'll invite them to come back up, and we'll have a few online as well. And then we can ask them some directed and some general questions. So our first speaker is Kate Copeland. She's the Executive Director of Strategy, Planning, Assets and Infrastructure at Metro North Health. Her role includes health service strategy and planning, with oversight for $3 billion of capital assets and $2 billion of capital projects across 6 hospitals and multiple community facilities. Kate has more than 25 years experience in the health infrastructure sector, including statewide health services planning and leading the planning, design and procurement for large scale and complex health infrastructure projects within the public sector. Kate was recognised in the 2021 Queen's Birthday Awards as a member of the Order of Australia for significant services in health infrastructure planning and management. Thank you, Kate.
Thank you very much, and thank you for the invitation to talk here this morning. Is it going to go to the slides? Got my clicker there. Look at that. I really appreciated the opening session and the presentations from Nick and Kate and Judene. And I think it's always a good day when you learn something new. And I'm pleased to say that I've learned a few new things this morning already, which is hopefully going to stand me in good stead. Yesterday, Metro North had a community engagement forum where we met with a range of our Aboriginal and Torres Strait Islander elders, community members and staff as part of our journey along the road to health equity. So it was very timely to have that presentation from Judene this morning. Just a quick overview of what I'm going to talk about. This is energy building and scope. So just a quick overview of our sustainability strategy, green buildings, perhaps not as visionary or targeted as Kate was talking about. I think she was talking about 2040 and 2045. At the moment, Metro North set its target for 2050, but we'll see how we go and where we go next. The first thing I think we need to recognise is that you need some commitment from the top when you're addressing some of these challenging issues. And so one of the things I'm really pleased to say is that Metro North Hospital and Health Service, which is the largest health service in Queensland, has commitment from its board. And in February this year, we put to that board a sustainability strategy to take us forward for the next 5 years, which has been endorsed by the board. And the areas that we're looking at are the fairly traditional areas of waste, energy, water, food, transport and procurement. And after watching Kate's presentation this morning, I realised that one of the areas that we have not yet engaged as much as we need to is those who are involved in the delivery of health services. Metro North does have green teams at each of its facilities, and the intent is that the top-down policy and governance and the bottom-up grassroots enthusiasm is reflected within those green teams. But the 5-year strategy is divided into 5 key elements, and those are monitoring, initiatives, partnerships, workforce and facilities. And I'm going to concentrate today on the facilities component. As I've mentioned, the intent is that we want to drive our facilities to net zero by 2050, and perhaps we can learn from others within this forum and others to achieve a faster rate than that. We'll see how we go. We're trying not to scare the horses at the moment. Some of the things that we're already doing is moving to electric vehicles. Earlier this year, we got our first battery electric vehicle, affectionately known as BEV. Metro North currently has 4 electric vehicles, and by early next year, we'll have a further 12. So it's not a huge proportion of our car fleet, but we're on the path towards having all electric vehicles, all electric passenger vehicles by 2026. In addition to that, we've been working with our gardeners. We've got, as mentioned, 6 hospitals and 35 or so community centres, quite a large gardening fleet. And so this year we've actually transferred all of their equipment, with the exception of the very large mowers, to electric. We've not yet found a manufacturer for large mowing equipment that can meet our requirements with an electric vehicle, but we're continuing to look at what's available on the market. We're also looking to replace our BEMS buggies and the motorbikes used by our security people where we can. So with the strategy, I think no surprises here. Looking to ensure that we've got both leadership and organisational commitment. I think we're very lucky. We've got a very passionate Director of Sustainability, and the team who work with him and those across all of our facilities are likewise passionate about what they do. We're trying to embrace staff engagement. There's been a groundswell across our facilities for many years, and we're trying to provide them with forums and opportunities to progress good initiatives. As I said, trying to consolidate those types of current initiatives, providing a framework to develop new initiatives. One of the things that I've been impressed with is the area in the waste management. Earlier this year, we had a a one-day forum looking at waste management, and there were a range of different companies that came along and talked about what they were doing in that space, which is really exciting. And then we're highlighting the monitoring because I think people have got to see that there's recognition for what they do and when they achieve targets, and then you can move on to set new targets. At the present time, Metro North Health is preparing 7 business cases for investment in our building infrastructure. And rather than have 7 different teams go off in 7 different directions, one of the things that we've done is to prepare a sustainable design guide. And that allows each of the teams to work in a coherent way to address these issues. And the other thing that I think it does is it has sustainability embedded within the planning and the design of the facilities, rather than as an add-on, where it's very easy for people to go through a value management process and just reduce it or take it away. We've had that experience in the past. We try and learn from past experiences. One of the other key things is to ensure that we've got a whole of life approach. And, you know, there's a lot of commitment that's made, or verbal commitment that's made to a whole of life approach, but sometimes in the enacting, it loses some of its focus and cohesion. So we need to look not only at the construction and operation of the facilities, but also what happens at the end of life of facilities and looking at future deconstruction. Key for Metro North, as one of the 16 hospital and health services within Queensland and working with the Department of Health as a system manager, is ensuring that we're aligned with other government governance and policies in this area. And so we've ensured that these guidelines that we've prepared align with the Queensland Government sustainability policies and the Queensland Health standards and requirements. Our guidelines should serve to complement existing documents, not move away from them. When developing the guidelines, we're acutely aware of the affordability conversations that have to happen. During the development of business cases where you're seeking funds, you need to ensure that you've addressed that. Every time I meet with the Department of Health, they talk about the fiscal constraints within which we have to work. But the cost of moving towards carbon neutral will be far less for organisations than the cost of adaptation once you've got buildings that are not fit for purpose in the future. We believe that we've taken a pragmatic approach to this. The intent is building better facilities, and we believe that a fairly modest investment around about the 3% of construction budgets will help to achieve these. So we haven't moved right out to the far end of what is conceptually possible. We've taken the tried and true and just looked at those as this is the way we should be building now, and also trying to prepare for the future. We also forecast that there'll be positive flow-on benefits from having better buildings for patient outcomes as a result of improved amenity for patients, for their visitors and for staff, better materials selection, improved air quality, and enhanced access to green spaces. At each stage of the design and construction process, the guidelines have a role to play in evaluating and verifying where the targets have or have not been met. We're cognizant of the fact that we may achieve better outcomes from a new build than we may from a refurbishment building or a redevelopment, and therefore each project could have slightly different criteria applied to it. And that's okay as long as it's within the framework. So we've developed a tracker. It's a pretty basic tracker, uses a spreadsheet, but it's completed by the design team or the constructor, depending on the status of the project. And irrespective of the stage of the project, it will be the project managers who help to drive this process. The tracker, in the form of a spreadsheet, as I said, lists each of the targets grouped by key theme and requires the design team or the contractor to input data. Ultimately, Metro North Health will be able to understand the carbon cost of constructing and operating the facility over its design life, and this can be incorporated into our overall carbon footprint. Over time, we'll also understand more about the costs of not meeting some of these targets, which will allow us to hold informed conversations with our funding providers. And of course, moving forward, we're keen to ensure that we build on the momentum of what we've got. In 2021, Queensland government's made a commitment to achieving health equity for our Aboriginal and Torres Strait Islander people. Each hospital and health service is currently on a journey to develop, with their First Nations communities, a strategy and an action plan. Consistent with this requirement, Metro North Health is also progressing a built equity framework, using co-design processes for health facilities to try and ensure that they better reflect the cultural requirements for our Aboriginal and Torres Strait Islander community. I have to emphasise that's just one small thread. In addition, and consistent with comments made by earlier speakers today, we're also looking at our procurement partners, working with companies that have both policy and action plans towards net zero, initially as a decision point, but as Nick and others have outlined, we do intend that from a point in the future, we won't work with companies that don't have that commitment. And as I've also mentioned, working to have an all-electric fleet by 2026. Actually, the Minister for Energy and Public Works has made a commitment for Queensland Government that all vehicles will be electric by 2028, I think. So we're just trying to short circuit that a little bit. So thank you very much. I hope that's been useful and gives you a little bit of an overview of what Metro North's doing at the moment. And I couldn't finish without saying a big thank you to all of the people on the sustainability team and all of our facility green teams. Thank you.
Thank you, Kate. It's certainly really encouraging to see that so much is being done close to home as well. Next, I'd like to introduce Associate Professor Wendy Miller. She is an Associate Professor at the Queensland University of Technology. And Wendy initiates and conducts multidisciplinary and transdisciplinary socio-technical research in energy efficiency, renewable energy and resilience in the built environment, in particular housing and healthcare facilities. In these settings, her work includes a wide range of issues, including the impact of climate change on buildings and occupants, the importance of resilience, and the interconnectedness of energy, indoor environment quality, and occupant health. Thank you, Wendy.
I'm pleased where this talk has been scheduled because it follows on really well from things that we've already heard today. So my area is looking at the how do we get to the net zero, and in particular regarding the energy part of healthcare buildings, hospitals and aged care buildings. So this work is being done under the Innovation Hub for Affordable Heating and Cooling, which is a coordinated project or set of projects between a number of leading research organisations, the air conditioning industry of Australia, because air conditioning relates to about 50% of the energy use in hospitals and aged care centres, and the Australian Renewable Energy Agency that is looking at how do we get more renewable energy into our buildings. So as part of that work here in Queensland, we actually have 2 living laboratories, so Queensland Children's Hospital and Fernhill Residential Aged Care at Caboolture, where there are 2 buildings that we've set up parts of those buildings to be able to test and evaluate emerging technologies that can help those buildings reduce their energy use or change the way their air conditioning system works or put in more renewable energy, etc. So we've been testing a number of products over the last few years. So in healthcare facilities, as I said before, roughly 50%, slightly more or less, is directly related, of energy use is directly related to heating or cooling or providing ventilation to the spaces. So that's the area that we want to look at. And someone asked, I think, previously, how are hospitals reporting on their carbon emissions? All public hospitals in Australia report to the federal government every year on their NABERS rating, which is their annual energy consumption and the associated greenhouse gases with that. And generally, that is only reporting the total energy use used by a hospital, and this year also at some aged care facilities, based on a kilowatt hours of energy per square metre of a hospital or per occupied bed day, and to some extent compared to the heating and cooling degree days. So there is some sort of reporting about energy use that happens in public hospitals, but not in private hospitals at the moment. But that in itself is not enough to provide enough detail about how can we actually move and reduce our carbon emissions. So the graph on the right is looking at a study from the US, which is actually looking within a hospital, how are different departments within the hospitals using energy, and can we use that information to find pathways forward to reducing energy use. So one of the areas of research that we're particularly interested in is how can we better align energy and health things, because we're all under, clinicians are under budgetary constraints, so are the facilities managers. Can we find win-win solutions for things? So this image is just one image of the things within a patient room, whether it's in an aged care centre or a hospital, that will impact on the indoor air quality of that room. So the location of the room according to the whole building, the room layout, microclimate, the ventilation strategies, materials, all of those things impact on the indoor environment quality of patient rooms. And the ones that particularly interest me as working in facilities management and building science are the microclimate and the ventilation strategies. And ventilation has been a really high priority with COVID lately. But ventilation itself, if you look from a building services sort of research perspective, the 4 objectives of ventilation practitioners is to maintain life, so to provide fresh air, to dilute and exhaust pollutants, to protect a building against moisture, and to contribute to thermal comfort. And ventilation experts do that through a range of parameters. So they need to know what the temperature and relative humidity are. They set airflow rates and the velocity and how the air is distributed in this room, for example, and then what sort of filters they use and the pressure difference in rooms, etc. But interestingly, if you ask all the facilities managers of all the hospitals in Australia now, most of them will say, we run our hospitals according to a particular standard, which is called the ASHRAE standard, which is an American Society of Heating and Cooling and Ventilation. But if you look at the history of standards, ventilation, for example, it's varied over time in response to an understanding of particular contaminants and what the focus of the contaminant is, and what the relative importance of different contaminants are. So we found that with COVID, for example, that there's been some spread through COVID because COVID was never something that ventilation was expected to have to deal with. It's also been based, ventilation standards based on concentration limits, which don't always, there's not always sufficient evidence to determine what is a safe level of CO2, for example, or carbon monoxide, and different building typologies and energy efficient requirements. But building service engineers are often required by their organisations to operate their facilities according to international standards or the national standards, but those standards have a lot of unknown unknowns and known unknowns in them. So what we want to do is look at how can we find some different key performance indicators that can take account of the complexities between the energy use. So in this image, if you think of the dashed line on the outline as a building, so this hospital, for example, and within that hospital, we have the complexities of how do we deal with the different people who occupy that building? How do we deal with the finances of building and health costs? How do we deal with greenhouse gas emissions? And how do we deal with climate change resilience? And within all of that, energy plays a big role in that, and the indoor environment quality, so the thermal comfort, the visual comfort, acoustics, indoor air quality, and they're all interrelated. So if we develop some standards to say all hospital rooms should, wards, for example, should be run at 22 degrees, because that's what some people say is the most important temperature. That will impact on energy, it will impact on indoor air quality, etc. So there's a lot of complexities. But one of the visions that we have is that as we move towards different health delivery models, so from home, etc., and to delivering climate change, that we can have a range of different sensor systems and key performance indicators that we can use to change what we need to do. So from a key performance indicators, we've made some recommendations to our knowledge sharing task group for renewable energy in healthcare, that aside from doing whole of building campus energy use and greenhouse gas emissions, we need to have many more key performance indicators to measure our progress. And some of those include resilience metrics. For example, if an aged care centre loses power, often the emergency power is not set up to run the air conditioning. So if you lose power and there's a heat wave, what do you then do with the people in that sense? So the next steps for this particular funded project from ARENA is to develop specifically a renewable energy roadmap for healthcare. So what are the specific tasks that we can do within the next 10 years to move healthcare to reduce its energy use and increase its renewable energy. And as part of that, we do actually have a national healthcare knowledge sharing task group that is open to anybody. And we have our next meeting later this week if anyone wants to be involved in working towards that roadmap. So thank you very much.
Thank you, Wendy. That's an area that's certainly very interesting, particularly in light of the COVID challenges and challenges of future pandemics and climate risks such as heat and smoke. Next up, we have two presenters. We have Jack Hooper and Judene Andrews. Judene Andrews is UnitingCare's Manager for Environmental Sustainability. Under Judene's leadership, UnitingCare has achieved many milestones towards its emission reduction targets. In the last 3 years alone, UnitingCare has invested more than $4 million in energy efficiency upgrades and solar, decarbonised their passenger fleet, and introduced innovative recycling streams into their hospitals. Jack Hooper is the CEO of Gem Energy. Gem Energy was founded in 2013 with the simple intention of providing long-lasting, turnkey renewable energy solutions. Jack has been the principal contact for the rollout of solar, battery storage, and LED lighting for major clients, including Friendly Society Private Hospital, Australia Zoo, Cleanaway, Catholic Education Rockhampton, and QUBE Logistics. Under Jack's leadership, Gem Energy is positioned on the forefront of innovations that provide organisations an easy pathway to transition to 100% renewable energy. Thank you both.
Hello, everyone. I too would like to acknowledge the traditional owners of the land on which we meet today and pay my respects to elders, both past, present and emerging. So UnitingCare is also a co-partner of today. So it's great to see so many of you here and also online. I think there was over 200 people attending, so really good news. I'm just going to be talking about the 100% renewable energy commitment that we've made within UnitingCare. So a little bit about who we are. So we have more than 460 locations across Queensland, 4 private hospitals, 2 major ones here in Brisbane, the Wesley and St Andrews, as well as Buderim Private and St Stephen's. We also undertake the Lifeline Crisis and Lifeline Retail as part of our organisation, and we have 10 Lifeline Crisis contact centres, and we've got 56 residential aged care, which you'd most probably know as Blue Care. And we are actually the 2nd largest employer in the state. So we have over 17,000 employees and we have 9,000 volunteers. So just a really quick around. So why is sustainability for UnitingCare important? It's part of our mission. It's part of our DNA. Environmental stewardship was embedded in the Statement to the Nation back in 1977. We also recognise that to improve the health and well-being of individuals, we also must preserve a healthy environment. And our clients and our residents and our patients are actually impacted the most when it comes to climate change. And we also know that environmental sustainability makes good business sense. And Jack will be able to tell you more about that. We also produced a strategy, a 5-year strategy, and by 2025, we have 6 key themes. And the headline act, I think I'd like to call it, is sourcing 100% of our electricity from renewable energy. And just by doing that, we're actually going to reduce our carbon footprint by 70%. If you have a look at that, 70% of our electricity, of our carbon footprint, actually comes from electricity. So to give you an example, we report under NGERS, 76 gigawatts of energy is what we use a year. That's about 76,000 kilowatts, so it's quite amazing. So how are we actually reducing it? So as you spoke, we've already committed $4 million into looking at how we can roll out solar, LED lighting, looking at universal remote controls within our HVAC, but also looking at how we can transition our fleet to 100% electric vehicles and moving away from fossil fuels. So this is our plan by 2025 and how we're going to get there. So we have 2 main components. One is looking at, and we've got another investment from Investment Council of $3.8 million in rooftop solar. We'll be looking at focusing on our residential aged care facilities, 22 of them, and also one of our hospitals in the St Stephen's Hospital at Hervey Bay. And the other part of it is actually procuring our energy so that we're actually procuring either through a PPA or looking at how we're going to purchase LGCs. Or there's other options around directly with an energy retailer, and also looking at how we can invest in renewable energy by way of an action agreement with a renewable energy project. So we're keen to have a look at what we can do. I'm glad to announce that Gem Energy is actually the preferred supplier when it comes to UnitingCare, and they're actually about to, if not today, sign a contract for the rollout of the $3.8 million on our 22 residential aged care facilities. So I'd like to now introduce Jack Hooper, who's the CEO of Gem Energy.
Thanks, Judene. And just for those that are wondering, which pretty most of you, recent shoulder operation, I've got a couple of weeks left. That was actually today that we finally signed the contract on that next phase of projects for UnitingCare. So that's a really exciting initiative. And I think you look at St Stephen's Hospital, and that's about a 700 kilowatt system going on that facility. So it's quite significant. So we're founded in Emerald in central Queensland, actually as a sort of one-man operation, and we've now grown to being one of the largest renewable energy rooftop solar providers and battery storage providers in the country. We've done quite a lot in the healthcare and hospital and education sector particularly. And this is a really interesting quote that I've seen. In order to meet Australia's commitments to net zero, every business will at some stage throughout the next decade need to define their path to net zero emissions. And defining that path is one thing, but figuring out how do we actually get there is an entirely different challenge altogether. And the shift is on. And the question is, will you be left behind? And if you are, what does that mean for your brand? And what does that mean for your organization, stakeholders and shareholders? And the businesses and organizations are moving under pressure from boards and from shareholders. And customers are starting to use purchasing power to push action on climate change. And one of the things that I heard earlier, which a lot of people aren't aware of yet, is that large organizations are starting to push targets onto their supply chain, and they're starting to say, well, if you want to continue to supply us, we want to see your pathway, and we want to start seeing some action. And employees are obviously starting to demand that their employers start taking more action in this space as well. And you know, what we've seen quite clearly in Australia is that this transition will be led by the private sector, and it's up to corporate organizations to show that corporate social responsibility and that leadership, and to start driving this change. And it's the simple facts, you know, 3 out of 4 Australians would choose a product made with renewable energy over one that wasn't. You can see the statistics yourself. You know, it's getting more and more important to start managing this transition and start acting sooner rather than later. So we all know that we want to get to net zero. That's how is the question, you know, and one of the primary areas of consumption for, you know, is energy, as you've seen with Judene's slide. And, you know, that's what has the most significant cost impact to a business as well. So if you can, you know, install a solution that manages your cost and generates a return for you, because at the moment, buying energy from the grid gives you a 0% net return. You get no return on investment from buying energy from the grid. But if you invest in assets that reduce your consumption, you do get a return. So, but the biggest challenge is, where do I start? What's the cost impact of putting in all of this solar? I don't have operational budget. Who do we go and speak to for this? You know, what are the risks? Is now the right time? What, you know, there's always questions around it. And the current approach that most organizations are taking is through a corporate power purchase agreement or an offtake agreement, where they essentially just buy all of their energy from a renewable generator, and then they buy the LGCs or the green certificates with that energy and say, we're 100% renewable. There's no lasting legacy in that. And those contracts are typically 1 to 5 years at each time. So, you know, we're actually getting to the point now where we're starting to run out of available renewable generation. So not everybody is in a position where they can just go and link to a wind farm or hydro or solar farm, because there's not going to be enough renewables left for everybody to do that. So the only way that we're going to get there is through a mix of behind the meter generation with solar, battery storage, reducing the load through other initiatives like LED and aircon, but also linking what's left essentially to in front of the meter sources. And what we're starting to see now is that the cost of generating renewable power is cheaper than buying from the grid. That's just a fact. The challenges with CPPAs, the potential, this is a corporate power purchase agreement, is the greenwashing. There is no lasting legacy. It's just organizations that have got the capital, buying all their energy from a wind farm and paying for the certificates and claiming that they're 100% renewable. What we want to start seeing is those organizations investing more into behind the meter storage and taking accountability for their load and reducing it, and then starting to buy from the grid where they need to. This is a really interesting slide. So renewable energy accounts for 27.7% of the total energy generation in Australia. And, you know, we can see, you know, where that's coming from. Queensland is very low in terms of renewable generation compared to other states like Tasmania. Tasmania have actually made a commitment to 200% renewable, and with the infrastructure upgrades, they'll start exporting more power into the mainland. So this is really interesting. So the current available large-scale renewable generation is 20 terawatt hours from wind and solar for 12 terawatt hours. Now, in the commercial industrial energy consumption space, which is what most of the people here would be in, there's currently 110 terawatt hours of load, and there's only 32 terawatt hours of renewable supply available. So the question is, where does the rest of that come from? And even looking at the AMO ISP, which is the strategy forward, at best, we should have about 40 terawatt hours of available renewables by 2040 if infrastructure upgrades occur and these renewable energy zones happen and interlinks get upgraded and so on. So as I said, in order to meet those 100% renewable energy targets, it's clear that organizations can and must install behind the meter solar and potentially battery storage. And this is how solar looks on a RACs or a aged care facility. You've got a lot of roof space. It's not as highly energy dense as something like a hospital. The solar system comes in during the middle of the day and it essentially offsets all of the load during the day, so that you're not using any energy. And then the dark area there is the energy overnight, in the mornings and afternoons, and that's the energy that would now link to a wind farm, for example. So in this case, you're probably 50% self-sufficient. That's possible on a retirement center, but if you look at a hospital, this is typically what we see. We've got very high energy dense buildings. We have absolutely no available roof space. So the question is, well, how do we offset more of our own consumption? And you can't unless you start reducing your own consumption through other energy initiatives. But we just have to look at linking more and more to either a wind farm, or very interestingly, start linking that site to the renewable generation on another facility you might own. Now that's virtual trading of energy. So we can start, and we can do this now already. If you've got a big retirement, aged care center in northern Queensland, you can essentially export energy from that site and directly feed it into a hospital here in Brisbane. So that energy would offset consumption here. And this is what battery storage looks like. If you want to charge a battery, you have to not only offset all of your daytime requirements, but you have to generate more to put that energy into a battery to use that battery later. And batteries just don't work if that's the only purpose for it. You need to build the value stack for batteries, which is about how can my battery support the grid when wholesale prices are high? How can my batteries be used to correct frequency? And if you start building out that value stack, all of a sudden it becomes viable. And in the last 4 or 5 years, we've delivered over $50 million of solar and battery storage projects for the education sector here in Queensland, for Catholic Education, Rockhampton and Townsville. And Catholic Education, Townsville are now 100% renewable. So this next initiative, just to wrap this up, that we're looking at is this initiative called Project 100, and it is about transitioning to 100% renewable. The CapEx is always an issue. It just always is, budget constraints. So we actually build, own and operate the solar system and potentially the battery system. And we just sell the energy from that system under a purchase agreement, just the same as you'd buy energy from the grid. And then the remaining energy is what you end up purchasing from the grid, and it all comes through on a single bill, and it's 100% renewable. And it's also sat as an OPEX, so it's an operating expense, just like your existing power bill. So we get over the CapEx hurdle, and we can also, this means that you could essentially from the 1st of January 2022, you could transition to 100% renewable. It's that quick. But as we know, the amount of renewable energy generation available is diminishing, and people are transitioning and making statements about transitioning quicker than the renewable generators are coming online. So there'll be a point where you don't have that option of procuring from the grid, so you have to do it yourself locally. So, but it's exciting, and seeing that, that transition to virtual networks and the virtual trading of energy between sites is really the next stage in renewable energy. And I think we've got some really exciting things over the next few years to look forward to. So I'll leave it at that. Thank you.
Thank you both. I think I speak for everyone when I say that's really quite exciting to hear what has been done and is being done in the private sector. And I think the challenge is really on to bring some of those strategies across to the rest of the healthcare sector. So our next, just checking. Our next speaker is online, and I'd like to introduce Susan Wilburn, who is the International Sustainability Director at Healthcare Without Harm. She is an occupational and environmental health specialist, having studied in nursing, public health, and epidemiology. Susan leads Healthcare Without Harm's work in collaboration with the United Nations and World Health Organization on programs in sustainable procurement, healthcare waste management, and mercury elimination. Prior to joining Healthcare Without Harm in 2014, Susan worked for 8 years at the Department of Public Health, Environment and Social Determinants of Health at the WHO headquarters in Geneva. Here she coordinated the Greening Hospitals Initiative, as well as the Protecting Health Workers project. Thank you and welcome.
Thank you very much for the invitation. Thanks to Doctors for the Environment and to CAHA for this wonderful seminar, which I feel privileged to participate in. I too sit on traditional lands of the Skokomish Indigenous people at the south end of the Salish Sea, which is the traditional land of the Coast Salish people. I'm on a floating home and experiencing the changes of sea level change. And you may have been hearing the Salish Sea connects Washington State with British Columbia and the floods that we are experiencing this week and dislocations of many people related to climate change. I'm going to talk today a bit about sustainable procurement and how we think of it and why it's important before talking about what are the supply chain components of healthcare's climate footprint. And as you have as one of the sources for this conference, the Healthcare Without Harm Roadmap for Healthcare Decarbonization, then to discuss carbon hotspots in the supply chain, as well as how you can begin this work to address scope 3 and supply chain emissions. And just a reminder that you and CAHA are a part of a global network. And I love to show that you are connected to all of us and that are a part of the 400,000 healthcare facilities in 75 countries that are members of the Global Green and Healthy Hospitals. So what is sustainable procurement and why do we care about thinking about the immense amount of products and services that healthcare facilities buy? We think of sustainable procurement as preventive medicine, and that it supports a high performance healing environment, attracting new opportunities for us to innovate, to model leadership to communities, patients, employees, and especially to other sectors as we lead by example. And not incidentally, in many ways can save money. As we know, many of the products that we buy and use in healthcare settings can be harmful. While they may be therapeutic for patients, they are harmful to the rest of the building occupants. And some of them are also harmful to all building occupants, including patients. The health sector represents 4.4, almost 5% of global greenhouse gas emissions. And as you've heard, if healthcare was a country, we would be the 5th largest country in terms of emissions overall. And it is true that 70% of the emissions of the healthcare sector come from scope 3, primarily the supply chain. And as we heard in this, the first speaker in this session, there is a great deal of waste that we're creating and we can prevent. So what we buy matters, and how we buy our products also matters. Thinking about the health sector as a leader for other sectors and leveraging our purchasing power to drive the demand for sustainable products. And as Nick Watts was saying, to drive the demands that we make of our suppliers to achieve net zero together with us, to have products that protect without polluting and protect occupational health and communities. When we look at sustainable procurement, and this postage stamp at the corner is from the Sustainable Development Goal 12, which is responsible consumption and production. We think about the 3 sustainability demands, those of environmental, economic, and social. So we're not just looking at greening the healthcare setting, we are also looking at sustainability in the broadest sense. And some of the economic drivers are looking at the total cost of ownership of products and not just the price, so that we factor in the purchase price, the use and end of use, preferably reuse. As I said, this is from the 2019 report of Healthcare Without Harm on the climate footprint, that healthcare's footprint is equivalent to 4.4% of net emissions. This is the breakdown in the pie chart of countries. You can see globally, Australia is contributing to 2% of all of the emissions of the health sector, and on a per capita basis, the majority of emissions. And in order to align the health sector and healthcare services with the Paris Agreement to protect public health from climate change, we must tackle the climate crisis and continue to integrate health in all aspects of climate. And it's quite auspicious that we're together here in the weeks following COP26. And I'm sure Nick Watts must have shared with you the excitement of the first ever health program in the middle of the UN Summit on Climate. We have to achieve decarbonization, and this is not all of our emissions do not contribute equally globally, and so we have a differentiated approach to achieve decarbonization while achieving health equity and climate justice between and among nations and within nations. And by doing so, transforming the health sector and contributing to broader societal transformation. I'm here to talk about Scope 3 and supply chain. Scope 3 emissions are primarily supply chain, but also include employee business travel and waste disposal. As you know, Scope 1 are the direct emissions from energy use in buildings, Scope 2 from purchased energy use. And again, we're looking at Scope 3 emissions for the next few minutes. From the global roadmap for healthcare decarbonization, we can also see that Scope 1 emissions represent only 17.5%. So the two Scope 1 and 2 emissions, talking about energy use, whether generated inside or purchased, are 30% of greenhouse gas emissions. And that just lets us know that we have to focus on the 70% of emissions that come from the supply chain. And you'll notice from this slide and a slide coming from the National Health Service that pharmaceuticals are a major contributor to those emissions. Purchased business services and health services is another important hotspot in the supply chain, and biomedical devices. Here's from the 2019 report of the National Emissions Snapshot of Australia, where you can see that Scope 3 emissions are 72% in these estimates. And this slide comes from data from the National Health Service in England, which you've heard about this morning in their leadership in making a commitment to net zero by 2050 and the progress they've made to date. What you can see in the pie graph is that 72% of the greenhouse gas emissions in one of their analyses of emissions of the health services and social care were from procurement and supply chain, where travel was 13% and building energy 15%. And again, you see this large piece is pharmaceutical transmissions. What we know from the NHS further analysis is that waste anesthetic gases, the use of anesthesia, and metered dose inhalers for asthma, a great paradox, that they relate to anesthetic gases 2.5 to 3% of the total emissions of the National Health Service, and metered dose inhalers is approximately 3% of their total emissions. And that paradox that those medications that we're using to treat asthma result that is exacerbated or created by air pollution are contributing to more air pollution and climate change. So how do we begin to look at these supply chain emissions and work together to reduce them? And this slide is developed in the thinking about the health system and then what the health system can and needs to do to work with suppliers. Most important is prevention and keeping people out of the hospital. So as we say, the most sustainable hospital is one that is not built because it is not needed. And the most sustainable health product is one that is not purchased because it is not needed and not used. That said, thinking about primary prevention to avoid acute care, and also thinking about the increase in e-health services, so people do not have to come to a building and don't have to be transported there. Then to look at where are the carbon hotspots, and I showed you a few examples of carbon hotspots in supply chains. How can we reduce the unnecessary use? We have a great case study from another NHS hospital, Great Ormond, about how they saved money, saved carbon, and reduced the use of disposable medical gloves, which were a carbon hotspot, then you reduce the use and reduce the waste. Another consideration for sustainable procurement is favoring and prioritizing those products that are reusable versus disposable. And in a comparison of greenhouse gas emissions in an eye hospital in India with an eye hospital for surgery for cataracts in England, the India hospital was 10% the emissions compared to the English hospital with similar patient outcomes and similar procedures. The difference was the disposability of the instruments being used versus reusability. It was one of the main differences. And then once making the practice changes, choosing less intensive products, and I'll talk a bit more about that. As you've identified hotspots in your supply chain, then identifying the suppliers of those products and services related to those hotspots, to work with them to implement the Sustainable Procurement Index for Health. And I'll explain the index in a moment. It was developed together between Healthcare Without Harm and the UN Development Program in the Sustainable Health in Procurement project, as well as inviting suppliers to join the race to zero. As you know, there are 2 facilities on, at least on today's website, and maybe after today, many more health facilities in Australia have joined the race to zero. It includes scope 1, 2, and a requirement to measure and reduce scope 3. Working with suppliers to consider their energy source, it is great to follow the presentation on 100% renewable energy of health facilities. Let's see the same goal for the factories that are producing our healthcare products. Reducing packaging and considering transport and distribution of products to favor shipping by sea or rail versus air. I spoke about the Sustainable Procurement Index for Health. This index has 4 key themes. This is a tool that can be used with suppliers during procurement events or outside of specific buying events to ask the suppliers to complete what is currently an Excel-based tool that was launched two weeks ago by UNDP and Healthcare Without Harm at a Sustainable Suppliers Forum. There are 4 themes: greenhouse gas emissions, resources, chemicals and toxicity, gender, human and labor rights. And I'm showing an example of the first level. There are 3 levels of performance that a supplier can, procurement officer can request or require. And within, this is showing the questions from level 1, asking the supplier, do you measure your scope 1 and 2 greenhouse gas footprint, and whether you get points, whether it's from a recognized methodology or another methodology, and then do you report it? And the greatest points within this procurement event are received by publishing publicly their greenhouse gas emissions. There are organizational questions as well as product-specific questions in this index. Most of the product-specific questions have to do with toxicity. So you are familiar with the roadmap for health sector decarbonization, and this slide is the 7 high impact actions for that are published in this document. So powering healthcare with 100% clean renewable energy, as we've just heard, is a major contributor. Then investing in zero emissions building and infrastructure will further, and we're starting at the 3 gigatons, slightly more than 3 gigatons of carbon. That is after we achieve the Paris Agreement. Third is transitioning to zero emission travel and transport. We also saw the picture of the first green fleet 2 speakers ago, and providing healthy, sustainably grown food and climate resilient agriculture. Plant-based food diets, of course, are low carbon, and incentivizing and producing low carbon pharmaceuticals. You heard me say that 3% roughly of the NHS greenhouse gas emissions was pharmaceuticals. I saw on a slide in a previous speaker that it was 1.7%. Anesthetic gas was a contributor to the total emissions. So look, and I noticed there's a poster presentation of eliminating desflurane. So an opportunity for incentivizing low carbon pharmaceuticals and then implementing circular healthcare and sustainable healthcare waste management. Within the Sustainable Procurement Guide of Healthcare Without Harm, we have a list of high impact priority opportunities. These are the opportunities around procurement of carbon reduction products and services. Again, renewable energy. We've heard about air conditioning. I was speaking about gases. We saw that lighting is 9% of the emissions in one of the previous sessions. So that is a low-hanging fruit to move to energy efficient lighting, transportation, and distribution systems. With that, I would like to say,
great.
that all of the work that you're working on together are transformational systems changes. And by doing so, the health sector can be a leader in protecting public and planetary health from climate change and an example to the other sectors. I have included a couple extra slides on references and resources, and I would like to thank you all for your attention and look forward to the panel discussion later.
Well, thank you very much, Susan, for that illuminating talk. And I think you've given some really good examples, especially of some low-hanging fruit for Scope 3 emissions that I'm sure we'll hear more on later. Next up, and also online, we have Dr. Kate Wylie. Kate is a GP who is passionate about climate action. She's based in Adelaide in Ghana Yurta country. Dr. Wylie chairs the Royal Australian College of GPs Climate and Environmental Specific Interest Group, and she also works with Doctors for the Environment. Dr. Wylie knows that climate change is a health issue and believes that when we frame it as such, we invite the concept of treating it. She believes that GPs have a key role to play in the issue by showing leadership on climate change. GPs can show our communities the importance of climate action to protect our health and the planet on which we rely. Thank you very much.
Oh, thank you very much for that lovely introduction. I'll just start my slides. Yes, so my name is Kate Wylie. I'm a GP, obviously. That's why I'm presenting on greening general practice. First, I'd just like to acknowledge country. So the nation we call Australia is stolen land. First Nations people have never ceded their sovereignty of their land, and respect is owed to all Aboriginal and Torres Strait Island nations and First Nations people. I'm joining you from Ghana Yurta, otherwise known as Adelaide, and hello to a group of people in Ghana is Namani. So Namani to you all, and thank you for having me. Just a little bit about me. I chair the RACGPs Climate and Environmental Medicine Specific Interest Group, quite a mouthful, otherwise known as the SIG. I chair and facilitate the After Hours webinar series for Doctors for the Environment, and am fortunate enough to recently be elected onto their board. I'm quite excited about that. I've written a website called Climate Medicine. I'm a member of the Al Gore Leadership Corps. These are some stickers I've had made up that I give away to people. And this is me presenting at a climate rally earlier this year. And this is a picture of my dogs. This is Chloe, so this is Chloe, and this is Ella. And the reason why they're there is to remind me to say that although today we're focusing on the human impact of the climate crisis, what we're doing to our planet affects every living thing, every plant, every animal, every fungus. And sometimes we can be a bit cynical about saving humanity, but when we're having those moments, let's think that what we really need to do is save all of nature. Here's another picture of Ella. How could you not want to save a beautiful creature like her? So today I'm going to talk about greening general practice. First, we'll just look at the RACGP's green commitment, look at our carbon footprint, our impact on other health sectors, our impact in our communities, and lastly, how we can green the way we practice medicine. So firstly, the RACGP has been, wanting to do stuff about climate for a while. They released their climate change and human health position statement in 2019, where they recognise climate change as a key public health issue. They committed to mitigation and adaptation strategies. They decided to advocate for policies to protect health, and they considered it important for general practitioners to learn about it, communicate about it, and research it. In December 2019, the college declared a climate and health emergency. This was during the Black Summer fires. And they also released a number of resources for GPs around, climate and health action, things like bushfire planning, thunderstorms and asthma, extreme weather events, the mental health impacts, etc. But what's most exciting, I think, is that last month the college set a zero emissions target. They've committed to an interim target. So they've committed to reduce emissions by 80% by 2030 and zero by 2040. And within that, that means, re-examining a lot of the internal systems of the college. They've appointed a sustainability officer, established a sustainability committee, and have agreed to work with interested stakeholders within the college, including us in the specific interest group. So I think that's a big achievement. Good on you, RACGP. When we look at our carbon footprint, I'm sure lots of you are familiar with this pie graph that comes from Malik's paper about the carbon footprint of Australian healthcare in the 2014-2015 year, where healthcare was given as about 7% of Australia's carbon emissions. When you look at general practice, we're this little red piece of that pie. We're only 4% of those emissions. And, one could be facetious and say, oh, well, we may as well just go home. We don't do much. But of course, that is a spurious argument. And we are not in isolation with the rest of the healthcare system. Also, this pharmaceuticals wedge, which is 19%, we carry a big part of that. GPs write a lot of scripts. And one of the things that we're very good at is keeping people out of hospitals by practicing preventative healthcare. We reduce the burden on hospitals, and that is a great way to reduce emissions. Looking at those three in a little bit more detail. So first, greening general practice. I've got an acronym. Let's make it better. So, all general practices are basically lots and lots of small businesses. And so when we're looking at greening, we're looking at ways to basically green our own buildings and green our own businesses. So the first thing obviously is B for building. That's your insulation, double glazing, having reflective surfaces on your roof, lots of stuff around that. E is for energy. And the simplest thing that you can do, I think, as a small business is switch to a renewable energy provider. I mean, that's something we can all do as households, certainly do as small business, and, only takes about 10 minutes. It's probably an action that everybody could do today. Looking at batteries and panels, obviously reducing usage and improving efficiency, turn the lights off, turn the computers off, all of those sorts of things. The first T is for transport. So the transport of our patients and our staff. Getting a bike rack as a small business is a great idea because it gives people a place to park their bike, and it also sends a signal that bikes are a good thing. Maybe an electric vehicle charger if you're so inclined in your car park. The second T is for trees. Obviously, trees provide shade and therefore reduce our heating costs. If you've got a deciduous tree that drops its leaves in winter, then you can have your buildings warmer during winter, reducing heating costs. And trees are good for biodiversity, and the biodiversity crisis is obviously a whole nother problem, but really big impacts on health there. The second E is for e-medicine, so e-scripts, e-communications, e-health, basically trying to retire the fax machine, which is rather ubiquitous in general practice. And R is for recycling and doing that properly. There's a lot of resources that people can get on this. The RACGP has released this resource, Reducing the Environmental Impact of General Practice. Our colleagues in New Zealand have this excellent and very robust research on greening general practice in New Zealand. And in UK, they've released a GP carbon calculator. And just as a watch this space, the special interest group is currently working on one for Australian general practice so that we can have practices measure their current carbon emissions and then work to improve it and be able to, measure their effects, which is obviously important. The next thing I want to talk about is pharmaceuticals. And I think there's, a lot of work that can be done here. We don't know exactly how much of that 19% piece of the pie comes from general practice, and something that we ideally would like to know. We're trying to find this out in the SIG, but we know that, it's pretty obvious that a lot of it comes from general practice. And things that we can do to reduce that is obviously avoid prescribing it in the first place. And this is about practicing preventative health lifestyle. So a healthy diet, a healthy plant-based diet is good for emissions, it's good for humans. Exercise, practicing these lifestyle things, nature prescribing, which is basically encouraging people to spend time in nature, which we know reduces cortisol levels, reduces blood pressure. It's good for your brain, it's good for your mental health. These things are available to us. The next thing we really need to be looking at is the de-prescribing. I'm sure lots of us in the healthcare world, we've seen people who've got 20 medications that they're on regularly. There's got to be room to move in there. Surely these things are interacting with each other and causing harm. And, really we need to be looking at that. And also the last one is prescribing medications with a lower footprint. There's not a lot of information on this. There is great stuff on inhalers, but limited data on other things. And I'd love someone to be able to tell me what's got the lowest footprint out of, say, Crestor and Lipitor, or out of Nexium and Somac. These things where you're prescribing things that are very similar in their actions and effects, and I could just reduce emissions by signing a script. Easy, low-hanging fruit for me, if only I could get that data. With the puffers, the meter dose inhalers we know have a big carbon footprint. So this wonderful little info from the UK, where we have 1 meter dose inhaler being the carbon equivalent of driving one car 175 miles, which is about 300 kilometres, versus using an Accuhaler, which is only 4 miles. As simple as writing a different script. And the last point I'd like to make about scripts is that when we do write them, we should ensure compliance, ensure that they are doing what we set out to do, because the next thing that they can do is help keep people out of hospital. GPs are great at reducing the hospital burden. We provide long-term patient-centred care. I have patients that I've known for decades. I know their families, I know their friends. And what that means is I know their health very well and can see when things are going downhill for that particular person. We know that continuity of care is associated with lower rates of hospitalisation, lower emergency department attendances, lower hospital readmission rates, and reduced mortality. We know that continuity of care means reduced healthcare expenditure and therefore reduced emissions. Reducing the need for hospital care and support for and use of general practice slows the growth in health expenditure. And we know that GP stewardship means that this reduces costs and unnecessary use as well. And we've got Kermit on the right there, who's prevented an unnecessary escalation of care. So it was easy to be green for Kermit that day. The next point I'd like to make is that GPs are community leaders. So 87.8% of Australians see a GP at least once a year. And of that, 80% see them more than once. More people see GPs than any other sector of the healthcare community, and GPs are in every community across the country. We're in First Nations communities, we're in culturally and linguistically diverse communities, we're in urban and rural communities, and we're in all socioeconomic strata. And what that means is, we're embedded in the communities we serve, and we have the ear of the populace. This makes us well placed to prescribe non-clinical services, well placed to talk about climate, And I think GPs showing leadership on climate change signals to their communities that climate change is important, relevant to their health, and treatable. And my absolute fundamental dream for healthcare is that every GP in the country fully understands the health impacts of climate change and is talking to their patients about it. And if we do that, we can help shift the narrative, make climate a personal problem for humans in this country, and therefore demand action up the chain, which is, of course, where we very much need it. On the right, we have George Crisp, who's from a general practice in Western Australia. All right, I'm nearly done. The last thing we can do is green how we practice. And the first thing, the most obvious thing, is to talk about it. Climate change is so often the elephant in the room. The climate health emergency, but is the most important health problem of this century, and we're allowed to talk about it. We talk about everything else. We talk about smoking, we talk about bowel habits, we talk about gambling, we talk about sexual health. We're allowed to talk about climate change. We can talk about the health co-benefits of action, asking people to follow a planetary health diet, talk about active transport. We can practice high value care, realise that everything we do has a carbon footprint. So avoid unnecessary tests, avoid unnecessary imaging, de-prescribing, nature prescribing, basically practicing preventative health and incorporating climate into the care plans that we provide for our patients. So basically, in summary, general practice is committed to zero emissions. It's got a low carbon footprint, but it can work really hard to reduce the impact of pharmaceuticals in Australia. We keep people out of hospitals. We have reach. GPs are in every community. Almost 90% of Australians see us. We can show leadership in our communities on climate and health and shift the narrative around the need for climate action, greening our own practice and be part of the bigger picture, because fundamentally we know that this is the decade for climate action. Now is the time for us to work together to save our beautiful, fragile planet and to end on a cheesy medical meme, because we are the antibodies kicking in as the planet fights its fever. All right, thank you for listening to me. Cheers.
Okay, thank you so much for a wonderful presentation. You, as well as being very inspirational, you almost inspired me to leave emergency medicine and go into general practice. Finally, I think, yes, last but not least, we have Dr. Ben Dunne. Now, he's a thoracic surgeon at the Royal Melbourne Hospital with an interest in reducing the carbon footprint of healthcare delivery. As part of an effort coordinated by Doctors for the Environment Australia, again, he is working to ensure that all new hospitals in Australia, including the new Royal Melbourne Hospital campus and the rebuild of the existing Royal Melbourne Hospital campus, will be powered entirely by renewable electricity. Welcome, thank you.
So I'm one of the thoracic surgeons working at Royal Melbourne Hospital, and I'm speaking to you today from Wurundjeri land. And I've got 9 minutes or so to tell you how DEA worked with the Royal Melbourne and Royal Women's teams to push for an all-electric design for the rebuild of the Royal Melbourne Hospital and our new Arden Street campus in North Melbourne. The aim of today is to present you with a framework for how you can influence change in your organization. And so you can walk away knowing that you too can bring your hospital a little bit closer to being net zero. We have seen some of this information already. We're not the fossil fuel industry, but we do contribute 7% of the gross national emissions. And per capita, we're actually the 3rd worst in the world. And as Nick Watts spoke to earlier today, we all took the oath of first do no harm, and we can't really truly say that we are living up to that oath with these emissions. Again, copying some slides from someone else earlier today, this is something that Kate put up just moments ago. So yeah, we can see that between public and private hospitals, it's almost 45% of the healthcare emissions come from the hospitals, and that doesn't even include the pharmaceutical component of the emissions. Next slide, please. So when we look at exactly the the emissions associated with the hospitals, although this isn't Australian data, this is data from the NHS, we can see that building energy use is probably about 20 to 25% of hospital energy. use across the board. And although it's not the biggest piece of the pie we can see here, it's certainly easier to tackle in the first instance than all the staff and patient travel, and even more so than all the procurement and stuff we buy and use every day in the hospital. Next slide, please, Ben. This is a graph which shows how we're doing in terms of our energy supply to public hospitals at this moment. We can see that at least back in 2018, at least, Victoria was probably the biggest culprit in terms of its use of gas for powering hospitals directly, as well as a significant proportion in New South Wales, but other states sort of a bit better at using electricity, although we know that a lot of the electricity is still generated by fossil fuels. Looking at the renewable energy use, Queensland was one of the better states back in 2018, but still only generated 10% of hospital energy from renewable sources. This does do South Australia something of a disservice as they've really gone a long way since then in decarbonising their grid. Next slide, please. So essentially, what's the fastest way to reduce your hospital emissions is to try to get off gas and onto renewable electricity. This is easiest to achieve in new builds. And what we want to do is try to do that and build momentum to start to decarbonise the energy supply across the healthcare sector. Next slide. So I started working at Royal Melbourne in the middle of 2020, and around the same time as I joined DEA and the Sustainable Healthcare Special Interest Group. We heard about the new Royal Melbourne Hospital and Royal Women's Hospital plans, and we saw there was opportunity to influence the design and advocate for an all renewable energy supply. Unlike a lot of the speakers you've heard from earlier today, I didn't have the wealth of experience kind of working in the sustainability sector that they did, but I was enthusiastic and very keen to help. However, as I was a new consultant in a new hospital, I think the most important thing that I did was, next slide, please. Getting in touch with the Doctors for the Environment Australia Sustainable Healthcare Special Interest Group. I was really able to draw on the experience of all the others in the organization that it is. They provided advice, lessons learned from other kind of hospital buildings that they had tried to influence before. And through that, we've put together some guides and a lot of resources that can be very helpful for others trying to do this moving forward. So we can work together to make sure that not just our new hospital, but any new hospital that you're involved in building has no gas or fossil fuel energy supply, is 100% powered by renewable electricity, is as energy efficient as possible, and ideally even offsets the emissions associated with the construction process. Next slide, thanks. So you'll probably already know your internal stakeholders and the important people you need to get signed internally, being your hospital executive team or board. There's also going to be a project director appointed for the new campus project. You'll want to know who your director of facilities is. Hopefully you're lucky enough to have a sustainability officer, but you'll also want to get in touch with your communications team and the senior and junior clinical staff societies. What was news to me was the existence of a state health building authority, the Victorian Health Building Authority here, but every state will have one of these. It's a branch of the Department of Health responsible for capital building projects. As well as the first step really in any new hospital build is the construction of a master plan, and that's often contracted out to engineering and an architect firm, and you'll want to know who's been contracted for that work. Next slide, please. So the next thing you want to do, and what the first step I did, was assemble some senior clinical support across the organization. You want to find out who's passionate about sustainability in your hospital. If you've been there for a little while already, you may already know who these people are. Your sustainability officer can certainly help you. I approached clinicians in some of the senior roles and secured their support as a priority. I approached the divisional directors, nursing directors, clinical education and training directors, as well as the chair of the Senior Medical Staff Society, and asked them if they'd be happy to commit to supporting a plan for an all-electric, ideally net zero approach to building our new hospital. Next slide, please. The next thing then is really to demonstrate support for this idea across your organization. What does this look like? For us, what we did was we put together a letter to the Victorian Health Building Authority, and we put that together as a Google Doc, and we were able to then circulate it as a petition, so anyone who wanted to add their name to the bottom could do so easily. The first thing though is I would advise you to make sure that you try to keep your executive or leadership team on side and inform your chief medical officer or director of medical services that you're going to do this before you start circulating a petition around your hospital. The easiest ways that I would recommend circulating is first sending it to those senior staff that have agreed to support this initiative. Their signatures at the top of the list give legitimacy to the petition and sort of give cover to any of the junior staff that might feel like they're sticking their neck out by signing a petition at work. Also very helpful to send it out through heads of units, ward nurse unit managers, allied health directors, clinical directors, and the RMO Society as well. And once you've garnered a reasonable number of signatures, you can then invite your leadership team to sign it or meet you to discuss your plans and your requests. Next slide, please. So some advice is really that we had some differing opinions on kind of how to apply pressure, but we felt that it was best to try and keep our executive team on side and not go to any media or use any social media early on in the piece. If you check your contract, there's probably a reasonable chance there's a clause in there that says you can't speak to the media about anything related to the hospital without running it past your hospital communications team in the first place. So it's important to look through these things. I wouldn't jump to going to any external organizations too quickly. But if you get resistance at the executive level, then that's an option you can pursue. Next slide, please. Once you have the attention of the executive team and the building authority, there's a number of very valid arguments you can make to promote an all-electric design to the hospital, as you can see listed here. If you get in touch with us at the special interest group, we can certainly help you put a presentation together. We want to reinforce the breadth of support across the organization for this initiative. And you can do that in another way, because as part of the master plan process, the building authority will have to have multiple stakeholder meetings with staff across the organization. So you want to have representation at as many of these meetings as possible, bringing up sustainability and an all-electric design. You want to be the broken record that they keep hearing from. Thanks very much. We're on the next slide. So building a hospital, so even the master planning phase of it is not a quick process. But any positive news should be fed back to those who've been supporting you along the way. To date, we've only been told verbally that the new Royal Melbourne and Women's hospitals will be all electric and powered entirely by renewable energy. But even that verbal announcement was very, very galvanizing for sustainability across the two hospitals. We have a new sustainability group in the Royal Melbourne Hospital. We've got 30 members. We're doing internal advocacy work, running improvement projects and research projects. And Yinggu, who is my counterpart at the Royal Women's Hospital, has also really reinvigorated their sustainability group there. And more importantly, I think the organization knows that we're the voice for sustainability in the organization and that they will be hearing from us. Next slide, please. So I wanted to finish on this slide because I thought that was probably the most important one and certainly the most helpful element of all this for me, was that as soon as you hear a rumor that a new hospital is going to be built, get in touch with Doctors for the Environment Australia, preferably even become a member, reach out to us at the special interest group. That's my email address there if you want to talk to me directly. We've learned a lot of lessons through a number of these campaigns over the last little while, and we can certainly help guide you through the process. Next slide. Thanks very much for listening, and a lot of thanks to all the other people kind of in Royal Melbourne Hospital, Royal Women's Hospital, and at the DEA Special Interest Group. It really was a team effort to get things this far. Thank you. And sorry for the technical difficulties. I don't know what happened there.
Thank you, Ben. That was really good to see how a lot of effort can have some really good results and how inspiring it is for those of us who may be in similar situations in future. Now, I would like to invite all our panelists up to the stage and including those online, and we'll have some audience questions before lunch. And if those of you in the audience here and online have the Slido app, you can vote for some questions that you'd like to have asked or add your own. We had lots of questions regarding sustainable building, but also the electric vehicle came up, and there was 2 questions surrounding moving to electric vehicles or even to electric hospitals. Can we congratulate ourselves in Australia where all our electricity is still produced from coal?
I think that's a very sensible question to ask. I was really surprised with Ben's slide when he was showing the extent of renewable energy in different states, because my understanding is that South Australia actually has something like 75% renewable energy, which causes some problems when it's offline, but that's another story. And I think it is a very good question. And there are initiatives, I think, in most states to move to a much higher proportion of renewable energies. So yes, it's a vexed issue.
Yeah.
I will admit the data on that slide that I had was from 2018, and South Australia has come a long way in decarbonising their grid since then. But yeah, I think if we're powering our hospitals with electricity kind of generated from coal, that's really not acceptable. And I have to say, I take my hat off for the Victorian state government for committing to powering all public buildings, including hospitals. Any electricity to the public buildings will be from renewables by 2025. So that's been a real advance for us.
I think something about electrifying fleets that is often forgotten, that at the moment, if you don't have an electrified fleet, you're getting your fuel from the local service station. The moment you electrify your fleet, you have to have the infrastructure to do that as part of your building infrastructure on your hospital campus site. So it has a lot of implications for the energy infrastructure that you have regarding your charging stations on your hospital or your RAC sites, and what that means for your peak demand and all your costs, etc.
Yeah, I have to add that Metro North, in conjunction with electric vehicles, is also putting in solar onto the car parks, which is where some of our recharge stations are.
Yeah, and I just want to mention UnitingCare, we've just gone into a partnership with Origin and Arena. We've just installed 12 EV charging stations on 4 of our sites, and the majority of those actually have solar on them. So that's what we're planning to do moving forward. And the battery, the EVs will actually become a battery for that facility as well. So that's something to consider.
Yeah, I think the role that EVs will play in the grid in general is a little bit understated at the moment, or just, it's not as evident as people might think. But we're coming to an issue at the moment with the network, where we're running into negative pricing of electricity during the day, because there's an excess of energy being generated and there's nowhere for it to go. So eventually people or staff will start coming to work, and there'll be EVs at work where staff can plug their cars in and they can charge during the day off of that excess energy, take their car home at night, plug their car back into their house, and then they can start drawing energy from their vehicle instead of drawing energy from the grid. So that and yes, if you plug your EV into coal, you really, that's a question of how effective is it. But if you are going to work and your building is powered by 100% renewable energy and you're charging during the day, then you're essentially just having an offtake with a renewable generator. So you're charging your EV with renewable energy.
Sounds amazing. Another question for you, Jack. If Queensland Health wanted to go 100% renewable energy by 2025, like UnitingCare or the Victorians, could we do it?
Yeah, it's not a case of if. It's of course it's possible. You just got to get through procurement, which is always the challenge, unfortunately. But it's definitely possible.
Okay. Yes, we have Susan online. Susan, you spoke about scope 3 emissions and how we can reduce those. Do you think that they need to be part of the mandatory reporting across healthcare sectors?
If a healthcare facility, if an institution is participating in the race to zero, they are mandatory. They are making a commitment to measuring scope 3. It's important to remember that scope 3 emissions are someone else's scope 1 or 2, the manufacturers and the suppliers. So you want to be aware to avoid double counting. And we are in the process of piloting and invite others to join a carbon hotspots component of the Healthcare Without Harm climate impact checkup tool. I saw another question about how to find ways to measure carbon footprinting. So there is a tool that's now a facilities-based activity tool for scopes 1, 2, and partially 3, and we're building it out. with a module on supply chain hotspots.
Thank you. Kate, you have another question. How big is your sustainability team and how do you manage to support all the volunteer champions at Metro North?
Our sustainability team, if you look at it objectively, is 0. But because we've got so many passionate people, we've actually made it a part of a whole range of roles. So how many people in your team, David, that are working on this? 6. So we've got 6 people at the moment within assets and infrastructure who are working on this, plus our waste and environment manager is also very active in this space. And then at each of the facilities, each of the hospitals and to a lesser extent in the community, the green teams are largely self-sustaining. So they're supported by the local facility service directors, but really they're grassroots teams that meet because they're passionate about it.
Okay.
There's no funded positions at this point.
Yeah, interesting. It seems to be a recurrent theme, at least in the public sector. We've got an interesting question, and this is probably for across the board. How can we leverage the salary of healthcare workers to go green? So incentives to salary package, an electric vehicle, e-bike, install home rooftop, divest, etc. How can we incentivize it to individuals working for an organisation?
I've always thought about, salary sacrifice on cars. People often salary sacrifice their vehicle. If the organisation could salary sacrifice, or their employees could salary sacrifice solar and batteries for their home, then I think people would be incentivised to do something like that. But it's all sorts of tax problems there, I suppose, that sound fun.
But interestingly, you can't salary sacrifice public transport. So I could salary sacrifice and buy a new Tesla, but I can't salary sacrifice my annual train ticket, for example. So there's some tax incentives, tax disincentives for doing sustainability.
We need a forum on greening the taxation sector or something.
But also the salary sacrificing, even for vehicles, generally requires you to drive a minimum distance of kilometres in order to be eligible for the salary sacrifice. So it doesn't encourage efficiency either.
Also, it implies running costs, and Teslas have very little running costs, so you have de-incentivized for leasing via salary sacrifice as well.
FBT.
Yeah.
Queensland government did have a mechanism whereby your bus tickets could be subsidised. And I know this because my husband had one. And it got so complicated because he could only use it Monday to Friday and he could only use it certain hours. And if he went out on the weekend and wanted to use the bus, they wouldn't accept that bus ticket. It was just so complicated. You've got to make it simple and easy to achieve.
I think there could be opportunity for large organisations that employ, big groups of people to associate themselves with a provider that provides solar and battery storage packages, and through that economy of scale, you can then provide a discounted offer through to for your staff and say, look, we've partnered with this organisation, they can do a solar and a battery project for you, at an X% discount, or they've got a unique finance plan, and that's something that we're seeing more and more now, especially with the cost of capital being as low as it is. If you can go in and put in a solar and a battery system and get a 6-year return on investment, or 17 or 18%, and you can now borrow money at 4 or 5%. You're using debt at 4% to get a return of 70. It's a no-brainer. But I think you need to get that, clear that fog of confusion about who do I go with, the right price, and I think those sorts of partnerships are a good way of doing that.
And I think that was something that was a value add in the contract that we had with Gem Energy. So that was another reason, going with a company such as Gem. Gem also, and I'm not speaking out of turn now, it is around with membership of RACQ, they give a discount, I think, to members of RACQ. So we've added that into our contract as well, so that our staff will get a discount on solar and battery storage.
Thanks for the plug, Judene.
We've had a couple of questions sort of broaching on general practice, other Kate. And a couple kind of touched on difficulties in some general practice environments with short consults and some GPs potentially being risk adverse, and kind of referring into tertiary care based on that, and also about issues with federal and state funding. How do we address this when we know general practice is so good at low carbon but high value care?
Okay, so there's a few things to unpack in that question, but I think when it comes to emphasising low carbon, high value care, really it's up to our organisations, so the RACGP, the AMA, CAHA, etc., talking with our federal government and getting them on side and recognising that carbon is that climate is a health issue. So, for the GP on the ground, I think that's something where we need the top tier leadership to be leading in that space. When it comes to GPs themselves, recognising the need for change, recognising the need to pursue sort of carbon-friendly healthcare, I suppose is a term. I really think that comes again to the college showing leadership, but also educating every GP in the country and every doctor and healthcare practitioner more broadly in the country on the health effects of climate change, that it is the greatest health problem of our time. I think the health profession reflects the whole of society, where we have some people, most of the people here, who are the alarmed group, and then we have the other end of the spectrum where you have people who are dismissive. We still have deniers in healthcare, which is, great sadness and needs rectifying, and that really comes to, education of doctors and, going from there.
Thank you. Now, we've got time for probably one more question. I just have to let everyone know, if you are going for a tour, you might just have to duck out now for the reception desk or welcome desk. So anyone who's going on a tour, if you just duck out now. And then this was an interesting question, and it probably can go for the panel, but potentially to Jack. And it's just talking about life cycle of solar and things like scope 3 and the actual production of solar panels, and how is that part of your company and the renewable energy sector in general?
Well, I'd probably just first off by acknowledging that it is an issue, and it's an issue particularly in Australia, where frankly the quality of workmanship and the quality of installation is very poor. Australia is, I think, the cheapest country in the world to actually buy a solar system. So, we see a lot of systems getting removed and replaced, a lot more than we'd like to see. And, we're starting to see panels going to landfill when they perhaps shouldn't. And that's just because of a lack of available recycling facilities here in Australia. And that's something that is starting to improve, and we're starting to see more of those facilities come online. But for example, we removed a whole bunch of panels recently that were damaged in a hailstorm, and we couldn't find anybody to take them and recycle them. And it was actually through some really good initiatives by Cleanaway here locally, where they could take the panel and they would essentially have to have 3 companies that they partnered with to be able to recycle 90% of it. But then that highlights some of the issues that we just couldn't find anybody to take that. So it is a problem, but I think when you consider if the system's installed correctly, they should have a design life of 25 plus years. And the new batteries that we're seeing now often have a design life of 15 plus years. So they've often paid for themselves 2 or 3 times over. And again, that's about looking at the emissions that go into making them. It's very important to partner with organizations that have someone like an organization like SunPower, for example. They actually have I think they call it a cradle to grave policy, where they guarantee that there's no landfill and that they've managed the emissions throughout that process. So, but if you buy a really cheap product, then inherently you can run into that risk of it being replaced before it should be.
I'd like to make a comment on that, in that often it's renewable energy technologies where people raise the question of, but what happens at the end of life? And really it should be something that we ask about everything. When did you last see a public debate about what happens to your iPhone when you replace it, etc.? So it's been used by anti-renewable industries for a while as a let's not go to batteries or PVs because there are issues not counted for yet, but it should be something we ask for everything that we buy.
All right. I've been told time's up, so I'd like to thank all of our panelists for a very interesting session. We do have a lunch break now, so if I can encourage everyone to have a look at the posters, you can vote for them as well on their poll on Slido. And we have some sponsor stands, so if you haven't already said hello, go have a meet with them. And then for online attendees, there are posters and sponsor stands as well as networking spaces, and they're available via the virtual event hub. And they'll be open in about 15 minutes. That's it, lunchtime. Yeah, come back out. When do we start back again? 1:15. There we go. Brisbane time. Oh yeah, for all the online people.